everybody. The meeting's being recorded now, so
Yes.
welcome everybody. It's wonderful to see so many people here. Thank you so much for joining us. I'm Brian Fisher. I'm a South East London GP and I'm chair of the Health Creation Alliance. We're in for a really exciting afternoon. We're going to hear some groundbreaking work in health creation, tackling health inequalities, and we hope and expect that ICSs can understand, value, and support these approaches. So the Health Creation Alliance is the only national cross-sector movement addressing health inequalities through health creation, and our mission is to increase the number of years people live in good health in every community. We're focusing today on the 5 public health inequalities priorities, and I guess most of you will be familiar with them. And we want to explore how these priorities can be achieved through engaging with communities through health creation. Health creation, don't forget, is the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their own lives and immediate environment. And when this happens, health and well-being is enhanced. There are 3 C's of health creation: building meaningful and constructive contact between people and within communities, and that increases our confidence, leads to greater control over our lives and the determinants of our health. And it's that control which makes the difference. People also need an adequate income, suitable home, engaging occupation, and a meaningful future. So that's about health creation and what the background to this meeting is. And I'd also like to frame this afternoon with a vital NHSEI guidance for ICSs called 10 Principles for Working with People and Communities, which was produced this month, very timely, as if they knew this conference was about to happen. And I'll be talking a little bit more later in the meeting about it, but sort of a couple of highlights from that is that says, put the voices of people and communities at the center of decision-making and government at every level of the ICS, co-produce and redesign services and tackle system priorities in partnership with people and communities, and use community development approaches that empower people and communities making connections to social action. So that's the sort of framing, I think, of this afternoon. And I hope that leads us to think about how health creation, inequalities, and ICSs can really make a difference to things going forward. There will be time for interaction in breakout rooms, so please limit the comments you make during the plenaries. Chat is available and we'll try and respond to questions. Most importantly, there will be a follow-up webinar between 12:30 and 1:30 on the 5th of October. And there will be an opportunity to talk about this conference and to take the issues and the queries and the challenges further. So this afternoon, we're going to first explore the concept of restoring health service inclusively with 3 great speakers. Then we'll look at practical, inspiring ways of tackling health inequalities, working with communities, and looking at 3 of the 5 inequality priorities. After the break, you'll have me again for 5 minutes only, exploring in a bit more detail health creation and the 10 principles. And at 10 to 3, we start the breakout rooms where we'll explore the priorities and the anchors of the vision. And finally, we'll have the fantastic Donna Hall talking about the priority, strengthening leadership and accountability. So that's the background. I think it's going to be a fantastic afternoon. We're all going to learn an enormous amount from each other. And I think it's time to get to work. So the first session was going to have Bola face-to-face. So Dr. Owolabi, Director of Health Inequalities of NHS England and Improvement, but she's been called away to see a minister, I'm afraid, but we do have a video of her, and then I'll introduce our next speaker after that. So can we have Bola's video, please?
Can I hear it?
There's no sound, Neil.
So it's great to be with you again today at this Health Creation ICS webinar. It's an absolute delight to be joining the discussion and to bring the national perspective to the conversation that we're going to have today. So in NHS England and Improvement, we have been having many conversations over the last several months with our colleagues from right across the system in coming to the vision statement that we've set out, which is to deliver exceptional quality healthcare for all by ensuring equitable access, excellent experience, and optimal outcomes. And this is set within the context of the roles of the NHS in tackling health inequalities. One of those being our key role as a partner within the integrated care system, working with our local authorities, with our health and wellbeing boards, our directors of public health, voluntary sector partners, community action organizations on the ground. And it is this role, this key role of the NHS as a partner within the integrated care systems that I really want to focus on in our conversation today. When the ICS white paper was first published, we talked about the 4 core purposes of the ICS: to improve population health and healthcare, to address inequalities in access, experience, and outcomes, and to ensure that we strengthen the role of the NHS in terms of social value, and finally, to make sure that we really do drive forward improvement across all of the domains of service. And so I want to focus on the health inequalities that I mentioned today, because we set out our 5 strategic priorities in the 21-22 NHS operational planning guidance. And we said we were going to restore our services inclusively, that we will mitigate against digital exclusion, that we will ensure that our data sets are timely and complete, especially ethnicity coding. And finally, that we will strengthen leadership and accountability. Because without leadership, without accountability, it is impossible to deliver on the other 4 priorities. And so I hope that through this Health Creation Alliance meeting today, that we will be able to get into a dialogue. And I really look forward to hearing from my esteemed co-panelists as they bring their insight, their experience, their expertise into this space to guide the conversation. And I hope that we will all leave at the end of this event feeling energized and equipped with new insight on how to genuinely collaborate to achieve our common purpose to narrow health inequalities. Thank you.
Well, that's great. Thank you very much, Bola, for that. And I'd perhaps highlight in that fact that Bola was talking about partners. So this is not about the NHS running everything. It's about the NHS joining up with others to make things better for the areas in which the ICSs are placed. So the ICSs are working together with other partners. The NHS has a tendency to take everything over, and we hope that that won't be the case in ICSs. Certainly, the Health Creation Alliance is very clear that this is a cross-sector working, and we can't tackle health inequalities without that. So to look indeed at how a place-based approach can restore services inclusively, I'd like to call on Jim Mcmanus to talk to us. And if you could tell us very briefly about you, Jim, that would be very helpful. Thank you.
Thank you. My name is Jim Mcmanus. I'm Director of Public Health for Hertfordshire. I'm the Population Health Lead for the Hertfordshire and West Essex Integrated Care System. I'm acting President of the Association of Directors of Public Health because the Department of Health has nicked our President and made her Deputy Chief Medical Officer. Actually, it's great. I do have to say, though, this is the third time Bola has stood me up for an event, and I'm beginning to think she'll do anything to get out of being on a panel with me. Can I start by saying one of the things Bola says about whole system, I've watched her live, particularly on the vaccine inequalities and on the National Vaccine Equality Steering Board, where she created an inequalities dashboard, and she used analytics at the service of communities. And I think, for me, she lives what she talks about. And I think that is probably my starting point for this morning, because we all know that health is not about the NHS. If it were, the health of the United Kingdom is not in a very good shape. If you look at our health outcomes, 80% of our health outcomes are not tractable by the NHS. Education, the start you get in life, the first 1,000 days, are far more important. And indeed, whether or not you live in somewhere with reasonable air quality, or whether or not you live somewhere with worse access to local services, is as important as a determinant of your health as anything else. So the first thing I think we need to do is understand what we do about a local system. And earlier this morning, we had Dame Carol Black and a number of other speakers, people who have been in recovery from drugs and alcohol, right through to clinicians, talking about the need for a whole system approach for health on drug and alcohol use. And there's a guy called Dave Hyam of Well Communities, who won the Municipal Journal Public Health Award this year for his work with Cumbria, who actually tries to put people in recovery at the heart of designing services. So place, where they live, and the system revolves around them, not them having to find ways into the system. So the first thing I think we need to inject into an approach going forward, looking at your building back together 10 key messages, is that every local part of the system is relevant and needs to be included if we are going to get health. And we cannot treat our way out of ill health, which is the second point I want to make. The National Institute for Clinical Excellence, as I still call them in old money, produced a cardiovascular disease impact report earlier this month. And one of the things that was very clear from that report, if you read it, is that the NHS has an important part to play in cardiovascular disease prevention, but actually the additive effect of local communities, of employers, 2/3 of our lifetime risk for cardiovascular disease is acquired in the workplace. The relevance of local communities and the relevance of local authorities in reducing cardiovascular disease is hugely important. And as Derek Wanless said in 2002, unless we actually harness that system, we won't improve. There's a couple of really good lessons from COVID that I want to share with you. The first is Sandwell in the West Midlands, where my opposite number actually worked with communities and handed some power over to communities. So they are now putting air quality monitors in mosques because faith in Sandwell is really important. But they have managed to get over double the vaccine uptake for COVID in Sandwell as West Birmingham, because they've worked with local communities with a sense of place. So it really does matter on the ground. In Dudley, and I'm picking the West Midlands for these two examples, they've actually worked with local pharmacies to deliver a COVID testing model that is cheaper than the national model and more acceptable to communities by using trusted local networks. In Bradford, they brought together a system to bring community intelligence from all communities into looking at COVID hotspots. There is a huge amount of learning that's been done in the last 18 months on COVID, and I pick out just 3 that can be applied right across a place-based approach to health. And I think if we miss that and make this just about the NHS, I think we miss the point. So how do we approach this? We know that every system is perfectly designed to deliver the results you get. So the drug and alcohol system delivers poor recovery because it actually isn't working together effectively as a system. And systems talk can often be really quite nebulous. But if we start out with some kind of attitude of humility and pick some local solutions, we can make differences. And I want to close by picking on Stevenage in Hertfordshire. Stevenage has, in its leisure services, a suite which is designed to help people rehab and rehabilitate and recover after surgery and strokes. They've got people out of clinical services into the community using services that have got them walking and cycling again. And it's fantastic to see, it's quite moving to see. And that is by dint of the fact that local people, like the leisure centre in Stevenage, it's right slap bang next to the railway station, they like the local community and the GPs and others work with them. So there's an example there for me, which over 3 years has improved outcomes for a bunch of people who weren't being moved on and rehabilitated and were still not living life to their full. My final point would be, there's an awful lot of frameworks around. There's the Marmot framework, there's a variety. I think we've got more frameworks than the average garden centre, and we need to pick one, stick to one, and use that one consistently, because sometimes our communities think we're inconsistent and indecisive, when in fact we're picking too many frameworks. So for me, it would be start with your local communities or our local communities and listen. And actually, if we can, give some power over. I hope that was reasonably coherent in the 7 minutes I had, and thank you for listening.
That was fantastic. Thank you so much for that. And you stuck to time, so well done. And I think that there are some inspiring examples there that you've talked about, which we really need to, it would be nice to have more details about those. And I'm glad that you've emphasized also that the NHS has relatively little impact on people's global health. It's obviously vital in some situations, but we really need to look at how the NHS can work in partnership. The five features that the Health Creation Alliance has developed to help local places do this work properly and do this work well. I'll be referring to those later on as well, because they are really helpful for local places to make a difference. I'd like to move on to Samira Ben Omar, who's going to talk and take forward the final point that you made, Jim, which was about power sharing. This is the aspect that lots of NHS organisations find the most difficult, and I think Samira is going to help us think that through. So Samira, please.
Yeah, thanks for that introduction. And I suppose I'll just, people often ask me about my role and what I do, and I tend to describe my role very much as walking a tightrope between system and community. So I work in North West London Integrated Care System, But if you ask people in the system, they'll go, oh, Samara, she does a lot of community. And if you ask community, I'll go, oh, she represents the system. She's a great tightrope to walk because it enables me to have both perspectives and actually kind of work within both system and community. And I think probably Jim has already highlighted probably about 50 or 60% of what I was going to say. So I'm just going to kind of summarize some of the things, but those were brilliant points and a great warm up for what I'm about to say. I suppose what I want to share is very much some reflections of some of the programs and approach and a couple of the programs that I've been involved in over the last 10 years around how you connect with communities around a different type of conversation to transform the way we deliver health and care services, and in particular around health inequalities. The approach is quite basic, it's quite simple. It's very much about how we enable a system that is connecting, that really kind of brings people together around a shared purpose, but also invites our system and people working in the system to connect with communities, not just as representatives of their organization, but also as representatives of their own individual personal self. If I bring myself into this space, then I would expect others to bring myself into that space. So the ask from our communities is that if we're going to actually ask them about their experiences, their personal life, we need to be willing to actually also present ourselves and commit to actually kind of sharing that within that context. The second is about health creating. This is about recognizing the critical role that communities and local people play in creating health and well-being and creating communities. As Jim said, 80%, there's so much evidence that actually suggests that 80% of what impacts on health happens outside healthcare settings. So how do we actually kind of how do we support our communities to do that and to do that well? And how do we, in a way, get out of the way to enable for us to do that? The third is evidence-based. So the idea is, how do we give parity of esteem to the stories that we hear versus the quantity data? So the quantitative data is critical, but actually it doesn't give us the whole story. So how do we actually kind of give legitimacy to the stories that our local people and communities tell us in the way that they tell us, rather than translating them into a system language that somehow dehumanizes the stories themselves? And the fourth one is, this is an iterative. This is about actually kind of going on a journey collectively. This is about actually kind of working together to deliver this, not to actually kind of do it individually. So how do we do that collectively to deliver the change that we want to see? So the two examples that I really want to share with you, the first one is the Community Champions program that we started. This was about 12 years ago. And really the Community Champions, we've got Chad here, he's in White City. And that was one of the first programs was actually started in White City. And the Champions program is using social movement principles. And it was about just having a conversation with local people. How do you have a conversation with local people around health inequalities in an area where the system perceives it to be actually they're not willing to engage, they don't want to engage, which is always surprising because communities have lived there for generations. So it's us actually who are new to the area, who are new to the dynamics as staff. Therefore, they're actually kind of, how do we connect with them? And it really started with one conversation that led on to another conversation about recruiting local people to help us make sense of the challenges. And it's very much on the principle that if challenges exist in communities, then the solutions lie there too. So how do we actually work with people and create the spaces for us to do that? Now, that's not just kind of a program. The idea is very much about really how we develop the evidence for that. Now, I'm mindful, I'm a community development worker by trade. That's what I do. That's what I've done for 20 years. Now, I know that actually in our system, the first thing that tends to go is if we have financial challenges is the community development budget, because it's seen as the fluffy stuff and it's seen as something that's not that. So for me, over the last 10 years, the idea is how we create the evidence base for a different way of doing things. So everything, I think for me, was about how we evaluate. It started as one hub. We've got 15 hubs across 3 boroughs. And actually, if you've seen one hub, you've seen one hub. They're very different because the nature of the communities and neighborhoods is very different. And it's about actually connecting to those who have the reach in communities, not always the community organizations. So some, in Wales End Estate, you'll see that it's Chelsea Theatre. In somewhere else, you'll see it's the church. In somewhere else, you'll see it's the community organization or the residents association. The idea is not to actually kind of be hooked onto the structures. It's about actually kind of identifying the reaches. The second example, exactly the same approach, but it was very much started pre-COVID, but actually the kind of when COVID and the first lockdown happened, it really kind of generated the urgency, but also the impact. And that's community voices. And it's about how, and it's kind of about conversations for change. The challenge that we had at the very early days of lockdown was, oh my God, you know, lots of people, I mean, from Northwest London, and we have Brent that had some of the highest number of deaths and number of COVID cases. So what is going on? What do we have? And how do we communicate with them? Well, so it was about how we bring the people together from those communities and actually kind of representative of the diversity of our local population to really help us make sense of that. Questions we asked was not about actually what NHS can do for you, what local services, it was just how are you coping, how are you feeling? If there's one thing we can do together, what we need to do. And what that generated, the first response was actually anxiety and fear. Now, no amount of communication, no amount of information is going to address that. So how we begin to have those different types of competition. We co-produced a framework really about how we capture and honor the stories. And these were co-produced with local people to actually kind of really help us articulate and deliver the change. I just want kind of some reflections, and I'm happy to share. We have some videos and we have lots of information on that, and I'm happy to share that. But I just wanted to share 4 things that we've learned throughout all of those programs. First one is actually people do more when they decide for themselves. Absolutely, the Community Champions program showed us. To be honest, when we asked local people to deliver, you know, lung cancer awareness campaign and reach 600 people, they reached 3,000 people because they're not motivated by our targets. They're motivated by something different. The second one is actually kind of community and faith spaces are the lifeblood of local action. I mean, the vaccine equity, the community immunity stuff that we did in Northwest London was absolutely, we wouldn't have done it without our churches and mosques, gurdwaras, but also our food banks, our community spaces. They mobilized to support us, not just in delivering what we need to deliver, but also kind of in, you know, they were actually kind of providing food for our frontline staff. They were kind of doing a whole host of that. So how do we actually kind of keep that going? How do we mobilize? How do we invest in that? The third one is if we've learned nothing, and certainly we also have Grenfell in our own area and the impact of Grenfell on communities, that structural racism and the wider inequalities have a negative impact on the health and well-being of our population. And we need to be able to actually kind of start acting on those things. I think there's been enough reports and papers to actually kind of help us understand what we need to do. It's just now we need to start doing something about it. And the final one is just measure what people value. You know, we may need to actually kind of look at increased employment, but actually for people, it's more secure employment, you know, a secure income. It may be actually kind of having less homelessness. For people, it's more about less overcrowding, a sense of community safety. Those are the things that people value. So how do we actually kind of, while we still deliver the things that we need to deliver, but also deliver the things that people value? And in everything that we've done, the joy of actually kind of co-producing evaluation frameworks and impact assessment with I mean, we did it with the Champions program around the social return on investment impact evaluation. That shows you the return on investment doubles as you scale up. So there's something in that in terms of how we grow and motivate and mobilize around those specific areas. So I'll just stop there. You're on mute.
Yep, here we go. That was fantastic. I think what came across to me is that you live these vital issues, the linking with communities, the way in which the system, you are the kind of link between the system and the community, and it's very exciting to see what you've done there. That is, I think we can all learn from that. And if you could perhaps put in the chat some links to websites or links to the data that you've developed, that would be really helpful for people to learn from. So thank you so much, Samira. That was really inspiring. So
and
I'd like
also, Brian, if I just add, also we will circulate everything afterwards as well. if people don't take the links down in the chat function, then we'll make sure we circulate them by email afterwards.
Cool, good. Thank you very much. So let's move on. We're now going to go into a session which will be led by Marin, our Chief Executive, as a double act, and we'll be looking at some of the other health inequality priorities, again, as always, through the lens of community. So Marin, can I hand over to you, please?
Thank you, Brian. So I'm Marin Simpson, and I'm the Chief Executive of the Health Creation Alliance, and we're absolutely delighted to be working with Bola and Grania and the NHS England and NHS Improvement Health Inequalities team to bring you this event. Obviously, we hope you're already inspired, but you'll continue to be inspired, and that will grow throughout this session. And Brian will be talking to you later about how we can work with you potentially on that. So we'd love to do that, to look at how health creation can address some of the core priorities that NHS England is now asking the health system to deliver on. So we've heard the national perspective from Bola, we've heard the place perspective from Jim, and we've had the community perspective from Samira. So we've set out the three levels, if you like, of the three different perspectives. This session is an opportunity to hear much more about some really pioneering work that's going on, led by frontline clinicians. Now, this work doesn't have to be led by clinicians, but in this instance, it is, and it's delightful to be able to have the next speakers coming to share what they're doing and some of the insights that they've gained. So all of them are true pioneers, and in the sense that they're, partway through what they're doing. So I wouldn't want you to think that we're presenting this as done and dusted. It's a journey that these people are on. So it's all work in progress, but they have made significant progress, and they've got some really exciting programs going. We'll hear about approximately 10 minutes from each, and they're mostly working at a hyperlocal level, but with communities, but also at a system level. So trying to get that change coming from the bottom up and happening across the system. So we'll be looking at both of those elements of this. Each one is going to focus on one of three out of the 5 health inequalities priorities. So initially, mitigating digital exclusion, and then ensuring data sets are complete and timely, and then accelerating preventative programs that proactively engage those at the greatest risk of poor health outcomes. And some of this work is happening despite what's going on around in terms of the NHS, and some of it's happening because of and being enabled to some degree by the NHS. So we'll explore that dynamic as well. And I'm going to introduce it to each speaker before they speak, but they will say a bit more about themselves as well. We won't have a break in between. The second half of this session, because it's an hour-long session, will be a panel discussion with these speakers. So there'll be opportunity to draw out further insights, and that will be led by myself and Ella Carman. Now, Ella Carman is a Health Creation Alliance member, an active member, and she's also has lived experience of multiple vulnerabilities. And her experience has been a driving factor in her developing her career in photojournalism and working often with vulnerable groups on that. So Ella is going to work with me as a co-facilitator to bring particular insight from the lived experience perspective on what we're about to hear. So looking forward to that session, the second half of this session. But before then, I'm going to introduce, we've got a double act to start with, Dr. Talak Mahmood, hope I've pronounced that properly, a GP at the First Care practice in Hounslow, and speaking with him, I think they're going to do something like a tale of two GPs, is Dr. Chad Hockey, and he's a board director and CEPN lead, clinical lead in Hammersmith and Fulham GP Federation. But they will say more about the details of their work.
Great. Thank you very much, Marin, and it's nice to join everybody. So we are going to do a double act. I'm going to go first, and then hopefully set the scene for Tal to wow you all with the stuff that he's doing. I'm going to share my screen and go for some slides. So hopefully you can see that. So this is, as Marin says, a tale of two GPs, and I think we're going to build on some of the themes here that Samira particularly was just talking about, because it's not just a tale of two GPs, it's a tale of how we do change within health systems. So me, in one of my other roles, I'm the clinical director of a PCN, trying to do inter-organisational change, trying to deliver system strategy, and Tal, as you're going to hear, practice partner, who the differences he's got in his experience of just doing it within his own organisation and what that means in terms of innovation and emergence. So I get told this a lot as a PCN CD. You must have online consulting, video consulting, online presence, etc., etc. And this predated the pandemic, and it went through the pandemic. Just as ironically now, we're also being told you must do face-to-face, ironically, in the setting of a digital talk. But of course, there's different modalities that meet different demand types and different needs. And what we're finding is we're getting the same criteria applied to us, irrespective of the variation in distribution of demand. As you've been hearing, we've got an equal distribution of complexity, which is very much associated with deprivation. So greater severity of complexity within each of the different domains of complexity, and greater volume across different domains. So what that means is that across our populations, we've got very different cohorts facing very different challenges, and yet we're being applied, given the same set of criteria through which to meet those challenges from a system lens anyway. So it lends me to one of the schemes that are created in North West London, which is a version of the GPs at the Deep End scheme. So the way that this is framed from the perspective of the CCG to us is it's about digital consulting, it's about improving access to general practice. And the BMA's stance on this is that actually there's different volumes of complexity that will dictate how many people you can safely consult in a day. So if you've got lots of people that are really complex, you can't do as many consultations without tipping into an unsafe zone in terms of your decision making. And so equitable funding would look like something like that. But of course, the reality is that you have Carhill doesn't recognise deprivation, so you have inequitable funding dependent on whether you're GP1 or GP2. So that's the deep end and the shallow end. And so it's not just the distribution of complexity, it's the system approach that perpetuates this, and the business model. So the focus on appointments, and I think you'll hear some of the ways that Tal has been able to address it as we go through. So the point of this is that when we're coming up with these kind of initiatives across ICSs, we very much do not have a level playing field in terms of the GPs that are the ones that are trying to translate this and implement it into practice. So this was what came to me from our CCG, is what are you doing about your eHub? So we were all asked to bring in eConsult as this tool for online consulting, and as part of it, we were asked to create this centralized hub whereby the eConsults would arrive. And so they get triaged or dealt with in a central, efficient kind of form. But what we found with eHub, with eConsulting rather, is that it really didn't work. It worked for some patients, but didn't work for most of our patients. People that didn't speak English. I had patients that were getting relatives to fill out the forms on their behalf. I had people that would, on the eConsult, it would look like they had a kidney stone, and when you actually met them, they had sciatica. It was the completely wrong type part of the body because they couldn't fill out the form properly. It didn't cope with the complexity that we were seeing in general practice in a deprived geography. People with multiple interlinked problems, social problems. There was no algorithm that could compute the various narratives of their life. Whereas I could just look at the name of the person that filled the form in, and I knew what was going on in their family context. And there were all sorts of unintended consequences that came on the back of it. So transactional care and generation of demand. And meanwhile, we had this whole cohorts of people locally that couldn't even get online. They didn't have credit to use their their phones, didn't have smartphones, computers, didn't have the confidence or skills. So we had this initiative that I was being asked to implement that really wasn't meeting the needs of the population as far as I could see. And it, I think, lends to this point: how can you improve access to care without involving the people that are going to be accessing care? How can I possibly be asked to implement a digital consulting tool without involving the people that are going to be using it? And when we tried doing this, some of the stuff that we heard was they wanted to be seen face to face. They didn't want to go online. We were asked to do digital consulting for group consultations for diabetes. And when we had focus groups, people said, I'd really like to meet up with other people with diabetes to learn from their experiences, but actually, can we do it face to face, please? And I started to realize there are all sorts of other initiatives taking place in the community that were disconnected and that weren't working synergistically. And that led to what we are now trying to do, which is to get this community partnership to try and target people that are digitally excluded around a skills framework. So this is our plan. Thinking about this not just in terms of it being about access to general practice and digital exclusion for that side of it, but actually in much wider sense. So a co-produced curriculum targeting people with different needs dependent upon what it is they want to use digital for. So for older adults, it might be contacting relatives, having a Zoom call with someone that's abroad. For other groups, it might be about completing some of the forms they need to complete for their benefits claims. We've got another work stream around creating a community coordination hub, which is really about recruiting volunteers and self-organisation. And then there's a final one about reducing practice variation. And you can see from the grid there, very little of that involves CCGs. Most of it involves different third sector groups or resident groups, because it's absolutely impossible to do any of these projects without them. We'll hopefully talk about a bit about this later on, but the difference here is, in terms of getting this set up, it's me in a PCN trying to do it across multiple organisations. I think we're going to hear from Tal now about his experiences at practice level.
Thank you, Chad. I'll just share my screen. Hopefully. Thank you for inviting me. I'm Tal, GP in Hounslow, I think. Let me just move that. So I'm just going to talk a little bit. So Chad's mentioned some rules and things that he has to deliver as a PCN director, and actually what we've done as a practice is thought, well, what is it that we can do ourselves, and what is it that what are the values and what is it that we believe in as a practice? And so we've spent years getting to this point, but this is a short video of what we think, the values that we're aligned to. Oops. I can't get this, sorry. Let me just move this across. One of the values is using computers.
HIOS stands for Healthy in Your Own Skin, and that's what we're all about. We have 3 core values. Personalised care, so we want our patients to feel confident about their health and able to look after themselves with our help. We want our patients to experience a personal service just for them. And that's why we focus on more than just medicine. We look at well-being too. Which brings us on to wellness. We promote physical and mental wellness. We want you to be strong in both your body and mind. And we care about our staff's well-being too. And also social responsibility. We care about the environment and our social community. And that's why we encourage looking after the world we're living in and helping others to do that too.
It gets better, I promise. So this is us. We've got about 13,000 patients and about 40 staff. And the key thing is that we have a culture of innovation, research and teaching. So we've got two bits, the practice, and then Highest Live, which is a webinar channel that we're just starting. So basically, we've developed stuff in the practice. Anyway, we've got a little chat bot, we're a training practice, where we work quite closely with Imperial, and we've developed a volunteer program for our patients. So I was going to go through some of an example of how we're working towards reducing health inequalities. So the key thing is we'll do sort of who we're supporting, what we're doing, and then how we're doing it. So the who we're supporting. So I think I love Jim's analogy of lots of frameworks and more than garden centres. Actually, the one that we've pinned our everything on is Professor Marmont's Health Inequalities report. And the key thing that we want to do is to reach out to patients on platforms they already use and make an emotional connection. If you look at Office of National Statistics, health apps are used about 15% of the population, but actually social media is used by about 70% of the population. So we thought, instead of doing stuff on an app, why don't we go to where patients are and speak to them in a language that they're familiar with? Again, if you look at sort of percentage of internet non-users, this again is historical data, but you can see that in 2011 there was quite a big difference in ethnicities about having online access, and actually that there's been a lot of convergence in that. So increasingly people are more and more online. The elderly are one of the highest number of people, percentage of people online. But actually, if in Professor Marmont's report, there's some really interesting observations, for example, that we weren't really familiar with. If you look at adverse childhood events, parental separation is a huge factor, and that's more of an issue in more deprived cohorts. And again, if you look at households with income below the minimum standard, children with lone parents are much more likely to be have health inequalities as a result. If you look at children and their A-level results and GCSE results, then if you come from poor, deprived backgrounds, then you're more likely to get worse results, which then determines your career in the future. Sometimes it's quite difficult to identify, nobody walks around with a label saying health inequalities. And so actually we've started looking at how we can use proxy markers to make sure that we're reaching the people that we want to. And free school meals is an example of one. So you can ask people if they have free school meals, or if they have English as a second language. Those are the two proxy markers to kind of try to reach the kind of people who are more likely to suffer from health inequalities. If one looks at employment, basically, if you don't have education lower than GCSEs, then your job is at much higher risk of automation. And actually, yeah,
I think we need to finish off in the next minute or so.
Oh, okay. I'll be quick. So what we've done is we've set up we've got 5 work streams in the practice, and they work on children and young adults, employment and the environment, and we're working on projects. There's not much point in going through it, to be honest. I can't do it in a minute. Yeah, I'll just stop.
Okay. Thank you, Tal and Chad, and great to get some insight both into the what's going on actually, what you're actually doing, and all the data that you have there, Tal, and also some of the challenges, the system challenges that are bearing down on you, Chad. We'll go on to the next speaker, and that speaker is Dr. Andy Knox, looking this time at ensuring data sets are complete and timely. So Andy is Director of Population Health and Engagement at Bay Health and Care Partners in Morecambe Bay, and also Executive GP for Morecambe Bay CCG. So thank you, Andy.
Hey, no worries. Good to see you all. Tal, I was really enjoying that. Like, you could have had my time.
I'm sorry.
No worries. We'll talk more.
I'm more than happy to have a discussion after. I thought I had 7 minutes. That was a lot less.
I guess we can visit it back in the panel discussion. But yeah, hi everyone. My name's Andy. I'm a GP up in Morecambe Bay in the northwest. Some people think that Morecambe Bay is on the south coast. It isn't. It borders Lancashire and Cumbria. And I'm also Director of Population Health across Lancashire and South Cumbria for our ICS. And so what I want to talk about today is the power of data in helping us engage with communities, and then how we can work with those communities differently. And it's amazing to follow Samira and Bola and Jim. Jim, great to hear you talking about Dave Hyam. He's actually one of my best friends. So great to hear you mention the work that he's doing up here in Cumbria as well. So over the last few years, we've been trying to work radically differently with our populations and really put social movement at the very heart of kind of what we're building together. And we've been blown away by the impact data can have in helping us change conversations with communities, but also empower teams to work differently. Because people love evidence. People love to see show me what's actually occurring, and then we can begin to think about what's happening together. So what we've invested in across Lancashire and South Cumbria, and it's work that we start in Morecambe Bay and we're now rolling out across all of our PCNs, is to make sure that we triangulate data really well to start with, so that firstly, we layer up data from general practice and from the acute trusts, from both the mental health trusts and from the acute providers. We add into that district council data and county council data, and then we bring in Public Health England data. And what that creates is this really beautifully rich tapestry of what we can give to our clinical directors and our community teams and our community voluntary faith sector leaders right in the heart of our neighbourhoods, and say, look, this is what's going on for your neighbourhood and your populations. And then rather than designing projects, and by the way, there are some really powerful bits of data within that. So for example, one of the highest predictive factors of having multiple disability and being pretty much unknown by your GP and having loads of admissions to hospital, for example, is having assisted bin collection. Well, GPs wouldn't know that, right? So having a map of people in their communities who have assisted bin collection helps them to be aware of some of the people they might want to work more proactively with. So data is really, really powerful. But then rather than us going old school NHS style, right, there's the data, we know what to do, we're going to design a project and do it to these people, we actually then sit with our communities and we share some of that data, because we absolutely believe in the power of people together to make a change. So one of the things we've been really influenced by is a philosopher called Marin Simpson, and she talks about how you build social movement. First off, if you want to build a social movement and you really want to see change happen in your communities, you must create anger, or you must stir up passion. The second thing you must do is challenge inevitability. And the third thing, you must then create moral alternative economies. And that's what we're about in Lancashire and South Cumbria. We want to get our people on side. We want them to see the data, see the massive injustice of health inequalities. We don't talk about index of multiple deprivation. We talk about index of multiple social injustice, because that's the reality of what's happening right across Lancashire and South Cumbria, right across actually the north, well, right across England, as Michael Marmot's report shows us again and again. But then we want our communities to say it doesn't have to be this way, and we can change this together. And then we try new things. And in order to try new things, we've got to put our money where our mouth is. So we've got invested to make sure that we've got a clinical lead for health inequalities and population health in every single one of our PCNs. We're going to be funding extra support and teams to work with them. And we're using a different formula, funding formula based on index of multiple social injustice, to make sure that we are putting more resources, more people into our areas of greatest need, because actually the funding formula works against us in that way at the moment. So we're shifting our funding and our resources into our areas of greatest need. And then with that data, with that sense of social movement and getting our communities to work with us and care about it, we then co-design and co-create the kind of projects that can really make a change. So I'll just give you some real quick examples. For example, in the city of Lancaster, we know that there are women in our community who are really not getting breast and cervical screening to the level that other women are. Those women are particularly from the Gypsy Roma traveller community. We wouldn't have seen that without the data. We wouldn't have known it. But then as we've built a relationship with Gypsy Roma traveller women, we've discovered all kinds of things we absolutely knew nothing about in terms of their culture, why they're maybe not coming for screening, what it might be that would change that, but also even just breaking down some of this stigmatization that goes with the GRT community and helping build a completely different kind of relationship. So now we've got women working with us from the GRT community who feel passionate that they don't want women in their community dying from breast and cervical cancer early. And now we're working together to change that story for the future. Dave Hine was mentioned, working with recovering heroin and drug addicts and homeless people to begin to understand actually what their needs are and what they need and what they would like to see change. We're working with people with, we know that the biggest killer in Lancashire and South Cumbria is cardiovascular disease, and so now we're working with our communities in our areas that have the greatest social injustice to share with them the reality that they're dying 17 years earlier than people 3 or 4 miles down the road, and how they might want to work with us and what the things are that would really make a difference to them to begin to change that picture rather than what we think or arrogantly assume that we know. So our starting point is really humility and deep listening to our communities. So the data, aligning with really radically working differently with our communities, making sure we've invested in the leadership and organisational development. A lot of the stuff that they've done in Wigan that I'm sure the wonderful Donna Hall might talk about later. But then what are the actionable interventions we're going to take as a result? So the data alone means nothing. Data shared with community combined with time and resource to work differently creates projects together that begin to change the narrative and prove that we can do things together differently. For example, for Gypsy Roma traveller women, recovering heroin addicts, people living with hypertension in some of our poorest communities. So I hope that's a little bit of a flavour of some of the stuff that we're getting on with, but I'll hand over back to Marin.
Thank you, Andy. That was wonderful, and such an energetic presentation as well of what it is you're doing there. And there's a couple of things there that I'd like to come back to afterwards to kick off the discussion. So the final speaker in this session is Dr. Jill Orrow. She's Community Development Clinical Lead for Healthy Hawley, and she the primary care networks there. And she's also a Programme Director for Growing Health Together. So she's going to speak about accelerating preventative programmes and the work she's doing with Healthy Hawley. So over to you, Jill.
Hi, everybody. Thanks so much for the invitation, Marin. And I'm just sitting here so inspired by all of the other speakers this afternoon. It's really, really incredible to hear all of this work going on. And I think, as Marin said in the introduction to this part of the session, I personally am very much in the early stages of a journey in this area, but it's a real pleasure to share with you what we are up to in East Surrey. So hopefully you can see my slides. Marin, can you see those?
Yes.
Fabulous.
Yes.
So as Marin mentioned, I'm the Programme Director of Growing Health Together, which is a place-based collaborative approach to prevention and health creation underway in East Surrey. And we're working collaboratively with citizens, with local government, with schools, charities, and many, many others who've come together around a overall vision to try and provide the conditions in which health and well-being can really flourish for everybody in our communities. And our work is really driven by a commitment to the principles of improving health equity, and also a commitment to improving sustainability in the broadest sense of that term. And our work starts with the social determinants of health, which we've heard referenced many times this afternoon already. Because we know, as it has been said already, that most of our health outcomes are influenced by factors outside of healthcare. And whilst this slot is talking about prevention, there's a huge volume of evidence to show that adopting healthy behaviours can prevent so many diseases. And yet we know that one's ability to adopt healthy behaviours is so heavily influenced by socio-economic factors and also the influence of the built and natural environment. So we want to look at all of these factors in our efforts to prevent disease and create health. And because most of these factors fall outside of healthcare premises, we are moving very much away from a top-down institutional model towards much more of a place-based, horizontal, inclusive paradigm, as highlighted in this Public Health England document a few years back. So like as Andy has up in the Northwest, in East Surrey, we have a GP lead for this work in each of our 5 PCNs. And each GP lead has protected time each week in co-funded posts, co-funded by the CCG and the PCNs. And through our work together over the past few weeks and months, we have identified that whilst we're all in a similar geographic area, actually the communities that we're serving are also unique. They're full of wonderful, unique people with different talents and interests and capabilities, and also different needs. And so because of that, the work that is evolving in each of our different PCNs looks quite different, but there are common principles in the way that we are taking our work forward. We heard just then from Andy about the importance of deep listening, and in order to be able to listen, and I think to be able to share one's stories, first we need to connect, and to connect as equal partners. And so that's very much where we start. We're connecting not only as healthcare professionals with professionals from local government and charities and schools and police, etc., but also as equal partners with the citizens who are really truly creating health in our places. And then we're trying to do this deep listening, not only about where challenges are, but actually about what's already strong and working to support health and well-being outside of the NHS, so that we can highlight what's working so that more of our population can benefit. And then in terms of listening to where the challenges are, there are all sorts of fascinating insights that we gain from listening to our citizens that we never would have gained through just talking shop amongst ourselves. And through our learning about health creation, from many on this call this afternoon, including Hazel Stuteley, Director of CT Connecting Communities, we know that if we want to reduce health inequalities in a sustainable way over the long term, then we need to be prioritising responses to challenges that are identified by the community, that are led by the community. And I'm now going to give you a few examples of where we are doing this in East Surrey. So in Hawley, which is the primary care network I work within, in terms of prioritising groups who might be at risk of adverse outcomes and ensuring that we're facilitating disease prevention in these groups, I think I would highlight firstly carers. So carers tell us, and our data tells us too, that they are at risk of adverse health outcomes. And we're supporting a number of initiatives. And I'm just giving you a couple of examples here. One is a wonderful community-led support group for people living with dementia and their carers, which is in the top left photograph. And then on the top right, we're supporting a group of carers of teenagers with learning disabilities who felt that local provision was poor and wanted to put that right themselves. And they're developing a really inspiring wellbeing space beside the river in Hawley, at which they're planning to grow vegetables, do water sports, traditional crafts, and more. Another group that we identified at risk of adverse outcomes are both the elderly and young people who've become much more sedentary through the lockdown. And in response to older people telling us they felt at increased risk of falls because they'd lost their confidence around physical activity whilst locked in their homes, we're supporting the community to establish new chair-based yoga to improve strength and balance. And then at the other end of the age spectrum, we're working with our local primary school and also Surrey Highways and our parish council around improving the active travel infrastructure in our area so that all families have the opportunities to walk and cycle to school safely, and that we can also support our staff in our practice, which is next door to the school, to also travel to their place of work in an active way, whilst reducing air pollution, which, as Jim right at the beginning said, is one of the critical factors that informs our health. I mentioned that the initiatives in development do differ between our PCNs. I don't have time to go into what's happening in each of the 5 PCNs, but just to quickly touch upon some fantastic work being led by my colleague, Dr. Uzma Aziz, who is the Growing Health Lead in Redhill. We just heard about data, and population health management data in Redhill revealed that our South Asian community had worse outcomes than the rest of the population in Redhill. So Uzma is working with the local mosques, with Surrey Minority Ethnic Forum, and with a diverse range of partners to try to work out and unpick what is actually going on, what is at the root of these health inequalities, and how can we put them right. And one simple example that she's working up at the moment is the mosques wanted to have access to a local area for physical activity and for doing cookery around healthy eating for those worshipping at their mosque. And Uzma and many others are now trying to bring that about. So we are very much at the early stage of this ambition, and we're still waiting for population health management program data for many of our PCNs, but already we can see that through our commitment to facilitate ideas that come from and work for more people, we're already seeing the benefits of that approach, not only for our patients and population, but for us working in the wider system too. And it's really, really exciting. I'll stop there and look forward to our discussion. Thank you.
Excellent. Thank you very much, Jill. And thank you to all our speakers. And I do apologise for cutting you off in mid-flow there. Hopefully we'll hear more from you in this this session now as we have the panel session. Neil, would it be possible to put the 6 of us to spot the 6 of us? Thank you. That's great. So we can see everyone's face. Possibly not Brian, but Tal and Ella. And Ella?
Hello, what do I need to do, something?
Neil, if you could spotlight Ella.
Yeah, there you are, Ella. Sorry, I couldn't find you. I was over the other side. Okay, here we are.
Okay.
There we are.
So one of the things that struck me is at the very beginning of our introduction, Bola talked about this session as being looking at what ICSs might do to address these 5 health inequalities priorities through health creation, and some of the powers that they might have is something I'm quite interested in exploring in this. Now, Chad mentioned, talked about the sameness of the system and how can we stop that from bearing down us, but also Andy talked about using a different formula, and I'd be really interested in looking at that a little bit, unpack with the group, and actually then we've had a little chance to do that, asking Ella to come in with some of her reflections on what's been said. So
thank you. I've got quite a few.
so we'll give everyone a chance just to say something about using a different formula. That's is that allowed? Are ICS is allowed to use whatever formulas they want in meting out the funding for this kind of work, or for indeed any kind of work?
Is that question's direct to me? Is that correct? Did I hear that correctly? Brilliant. Yeah.
Yes.
So we over the last few years have been really impacted by the state of health inequalities across Morecambe Bay and then across Lancashire and South Cumbria. And we wanted to have a more realistic and up to front conversation with our leadership teams about how we keep spending money compared to where the real problems are. So not only wanting to get upstream and actually create health with communities, but looking at the reality of what some of our communities are experiencing compared to others. Now, traditionally, funding is allocated in the NHS according to what's called the Carhill Formula. Now, formulas come and go and they change and chop around, but actually, if you look at what the Carhill Formula does, it actually works against communities that have the greatest health inequalities, which is crazy. It works significantly in favour of the South compared to the North, for example. So when we're talking about levelling up, I don't think that we can talk about levelling up if we're not going to have an honest conversation about finance and funding formulae. Like, we just have to put that on the table. So we started that conversation with our finance directors and our senior leadership team. And I brought to the table an as if. Okay, I wanted them to see the reality. So we, in Morecambe Bay, we have 3 prime districts. We have Lancaster and Morecambe, we have Barrow in Furness, and we have South Lakes, which is where the lovely, beautiful Lake District is. So we gave them an as if, and we said, look, and by the way, we've changed our language in Morecambe Bay and Lancashire and South Cumbria. So we would have talked about, so we said, as if, you got £500,000. And you want to make a difference to health inequalities. Let's look at where that health inequalities is and how, if we spent it only according to index of multiple deprivation, we've now changed that language to what index of multiple social injustice, because our communities do not like being described as deprived, and absolutely right. Therefore, we change our language according to what we're hearing from our communities. They suffer social injustice. They are not deprived communities. So that's really important to know. So we then said, okay, so if we had £500,000, how would we spend that money if we just did it according to index of multiple social injustice? And out of £500,000, we found that we would spend £232,000 in Barrow. We would spend £267,500 in Lancaster and Morecambe. And in total, we'd spend £428 out of £500,000 in South Lakes. Now that woke people up to, oh my gosh, this is really obscene. And then we looked at, so where do we actually have the best workforce? Totally in the places where we've got the best outcomes. All right. So if we were to reimagine a formula to put money where our mouth is, to say if we care about population health and through the tackling of health inequalities, that's our strapline, improving the population health through the tackling of health inequalities, how are we going to distribute things differently? And so obviously the leaders from South Lakes weren't happy with just getting £428 out of £500,000. So we went back and forth with all kinds of different proposals. And in the end, we came up with actually a very, very pragmatic response, which was, okay, 50% weighted on Carhill, 50% weighted on ethnicity and index of multiple social injustice. And there we are. We've found a much fairer way of distributing our funding and resources, which means actually the hidden levels of inequality, which you can see in places like South Lakeland, because there are incredible pockets of rural poverty, which are hidden by the great affluence. So we've got some stuff which we can do and allocate in that area, but we're also making sure we give a much bigger chunk and much better resources and many more people to work in our areas with greater social injustice and poorer health outcomes. So that conversation has then spread across Lancashire and South Cumbria. We now apply the entire population health budget according to that formula, which actually now disadvantages Morecambe Bay because Blackpool is the poorest neighbourhood in England. Blackburn has significant other issues. So you have to be careful with funding formula that you're not going to be too precious about your own area, but you really are passionate about social justice and you really do want to make a difference. So that's kind of been our journey, and that's what we're trying to do. We're now having conversations with the Health Foundation, with Lancaster University, with health economics professors, with NHS England even this afternoon, to look at how we might think about this at a wider level. And for us as an ICS, we're seeing how much of our budget we dare apply with this formula to see if we really can make a difference in this area.
That's fantastic to hear, Andy. Excellent. And I see the chat box going, lots of points there. Ella.
I just wanted, hello Andy, hello everybody. Finances and funding is not sort of in my remit, but I think that it seems like so much, they can't hide from this, these fantastic examples of work being done to highlight inequalities and to see, and communities equally to see that somebody's working on their behalf and their trust is being built. are they listening, the funders? Is it something they want to do, they're wanting to engage in, or is it something that they're had their pants pulled down over and having to do it? Or is it a case of, you know, they're actually wanting to work with you on this level?
No, I'd have to say it's this is all being recorded, so I'll be careful how I word this. I have to say we've got some of the best finance directors I've ever had the pleasure of spending time with. So across our ICS, we've got 5 lead finance directors, 1 from each of the 5 ICPs that make up our ICS. The one in particular I'm working with, he's also the finance director from our patches, guy called Andrew Harrison. Andrew came out of Greater Manchester. He's really well versed in the whole language of Marmot and health inequalities. He's just been a great friend actually on all of this journey. It hasn't been something where I've had to, you know, shame him into doing something different. He's genuinely a guy who passionately cares about social injustice as well, both because of his background and because of just where his passions lie. I would say we're not actually having to really win that argument. I think it might be a Northwest thing. We're just so used to health inequalities and social injustice being a reality for us that actually you don't have to win people over. This is something we need to change together. We just know it's the core of the reality of our health system. And when we're trying to dig ourselves out of the worst debt in England as a health system as well, that becomes an even more alive conversation, because either you keep pouring money into the black holes that is the acute trusts, or you dare to begin to spend your pounds differently and to try and make a difference to the stuff that will in the end actually save the system the money as well.
That sounds, thank you, that sounds great to know that it's coming from both ends, that it's going to meet in the middle, and it therefore will be more effective. That wasn't a question I'd normally have asked. I'm just trying to pick up on, I'll let, if Marin wants to come back in and I'll have a look at what else I've got here in a second, or I can carry on, it's up to you.
You can carry on. Let's give the chance for Gillian and Chad and Tal to come in.
Yeah.
Have you got another question, or shall I check in there?
I was making some more observations really, and it was that I'll let you crack on for a minute, and I'll have another look at mine and make a list of next, if that's all right.
Yeah, okay. I mean, I'd like to hear a little bit more from Tal and Chad about how you can get the balance between, you know, increasing digital online access and sort of actually working, you know, for quite a lot of people, but actually meeting the needs of people with complex needs at the same time. So, you know, Tal, you're the expert in this, and it'd be great to sort of, you know, is there a balance to be struck, or is that not what it's about? And then maybe for Jill to come in on the sort of the importance of providers and citizens working as equal partners, and the importance of communities leading on that. And maybe, I'm sure Ella will have some things to say about that as well. So Tal and Chad first, perhaps.
Yeah, I mean, I think there's just too much emphasis on digital. It's just a form of communication. So if you think of, it's one of many channels. And I think you should be talking about what you're trying to achieve rather than trying to talk about the channel the whole time. Some people like digital, some people don't. I don't think we should force it on people who don't want to use it. I think we should give people the choice. And actually, there is an argument that, you know, if you let the people who want to use digital themselves, then actually it frees up more time for face-to-face for people who prefer not to do that. If you look perhaps outside healthcare, if you look at industries such as banking or supermarkets, then they haven't forced people into a particular route. They've just given an option for people to be able to use a different channel. That might be suitable for some, might not be for others. It's kind of gentle nudges rather than mandates or orders, and then that needs to be done with a bit of support and training as well. So when you go to your bank, they will welcome you with an iPad, but they will show you how to use their online apps and online bits and pieces and the online machines. I think sometimes the words we use make a difference. For example, if you say patient, then that means one thing, but if you say customer, then actually the power then lies with the patient. And so actually, if you look at self-checkouts in supermarkets or self machines in service machines in banks, that could be renamed as self-care. So I think digital for the sake of digital is like, it's a bit dull. It's a bit ubiquitous. It doesn't really mean, if the best companies use digital without using that word, and they just focus on what you're trying to achieve and trying to make that pathway smooth.
Mm-hmm. Mm-hmm. Thank you. Ella, do you want to come in?
I mean, everything that is being presented today sounds really positive. You know, there obviously are some really good initiatives occurring, but then obviously from my point of view, I've seen examples of this, not just, there's been efforts made, but I'm obviously work in an area where there's all of these inequalities and neglect and deprivation is occurring. And then there's these attempts of all of this sort of initiatives to happen in the community, and it's really lovely to see, but it's hard to sort of imagine that really rolling over in time, or sort of take the pace that it needs to make a difference. How do you feel like this could be rolled out, you know, in other areas or by different ICPs that are not at the moment, ICS that aren't listening at the moment? How do you feel that this is something that can be kind of combined and used more thoroughly and kind of across the country? Like, obviously different places are going to sort of take different rates of improvements, and different communities work differently. In the worst ones, do you feel that this is something that's going to be progressively happening at a rate, at a fast pace or a slow pace? Is it something that we can roll out and sort of get across to all the different ICSs with these examples of great work that's been done in different areas?
Thanks, Ella. And obviously this webinar is hopefully part of that, but I'm going to bring in Gillian and Chad, because you've got that kind of systems view as well, I think, as well as doing the work on the ground.
Yeah.
Yeah. Is it okay if I go first? Chad,
yeah.
Is that okay. Thank you, Ella. Fantastic question. It's such an urgent question, isn't it, right now? I can only speak from my experience in Surrey, but what I see in Surrey is that those health creating principles in terms of connecting, listening and enabling aren't just happening with myself and colleagues with our communities, but they're happening at every single level of the system. So the only reason I and my colleagues are able to do what we're doing is because those in the CCG are enabling us to do it, and they're being enabled by the people in the ICS to do it. And why or how the leaders in our CCG and ICS have been able to do that, I'm not sure, but they are doing it. And I think, as Marin says, this type of event celebrating the type of work that can be done will hopefully then encourage other leaders across the system, across the UK, to do something similar. And then the second point I'd like to make is that within every single PCN, within every single practice probably in the country, there are GPs like myself, like Andy, like Tal, like Chad, who are so passionate about trying to heal the deep social injustices, the deep health injustices, and sort of the planetary health elements that feed into that. So there are everybody that we need, we already have, and everybody in the communities that we need are already there and wanting to do this stuff. It's just about that enablement and that listening and the joining up of resources so that we can all bring what we have and make a change.
Thank you.
I'm not sure if that answers it.
It does, thank you. You've really brought, you know, obviously it's about listening on a minor level, personal level, and on a major level like this. So hopefully this will have an impact. But I think the thing I've taken away that's really interesting was that data normally it's boring and it's, you know, for certain kinds of people to deal with. But actually it's been, by Andy, it's been sort of the example that it's so enlightening. It can be used. It's so strong, it can have such an impact, and that's what's happening. And overall it's allowing people to work together and making connections between things that otherwise would be falling apart, it seems, you know, you're actually making it stronger. So that's really interesting use of sort of, you know, digital age and computers, you know, what we've got to our advantage, we're using it to help communities. So that's great. Thank you.
Yeah, I'm going to jump, if that's okay. I can jump in. I'm not so sure. From my point of view, I think this is a question of culture, and so essentially there's a set of principles here that everyone's describing, which is about equity. It's about not focusing on providers. It's about focusing on people and places. It's about focusing on the things which drive people to be healthy, health creation principles, and it's about how those get applied at the level of community and the role of systems in enabling that to happen. And that's coming into a context whereby systems think, healthcare systems think, their role is controlling allocation of funds and budgets and monitoring medically based data to judge performance of providers. And so for that to change requires a change of culture. And Andy, I'm guessing that you've got people in a very senior level who totally get it and who've bought into that and who own the problem and are prepared to do something about it. And that's not what every ICS has got. That's certainly not what I've got. In my particular ICS, I can't even get onto the table of people. Like my CD role, I'm constantly banging away about, you know, what would work, what wouldn't work. It's like a constant fight to actually get heard, even from the grassroots up. So for me, it's a massive culture change that's required, and some of that I think could be enabled by NHS England by applying some of the principles that you're hearing from today and saying, ICSs, you must do X, Y, Z, because to some extent ICSs are vehicles, they're conduits to translate central strategy. You've got activated ICSs, and you're hearing from some today that are making these decisions themselves, but there's a lot of ICSs that aren't, that are just simply the conduits for a central strategy. And I think NHSE has got a real role to play there about embedding these kind of grassroots principles. So the number one thing that ICSs need to do is own it. If they're not prepared to own it, there is no hope. You're not going to get anywhere. They've got to accept that the variation in outcomes, the distribution of inequality that's there within their geography is due to the systems that they're creating. Until they're prepared to do that, you're not going to get anywhere. And then once you've got that, I think you've also got training needs. So the Deep End programme that we've done 3 cohorts in North West London now, is run on a wing and a prayer from me in a garden shed based on grant funding. And 16%, we've had the last lot we did, 1,700 people came onto the site, over 600 people booked on for sessions. 16% of these people that are motivated to attend sessions had ever had any formal training in the kind of concepts that we're talking about today. So there is a deficit of people with the kind of skills. We are an exclusive club here. We've been on this journey for a long time. This is not what most people are talking about, the people that are there at the grassroots. So there's a real training need that needs to happen in addition to this sense of things, of, you know, systems try actually owning the problem and making a change.
Okay, thank you for that. That makes sense, and I guess comes back to my initial question: is like, is this going to work? And obviously, in order to work, what you've just said there needs to happen, and people need, needs to be taken seriously. I mean, for what I do as a photojournalist, I shed a light on the problems that we're talking about within communities and especially in deprived areas. And I've taken on board training myself, trauma reporting and mental health first aid, because I'm going in and working with people who are suffering at extreme levels. I mean, the other day, a lady had a mental breakdown due to housing crisis, that, regeneration and gentrification, and local authorities not listening to people at all. So I'm seeing some of the worst effects of not listening. And then obviously, like I said, people trying their best, but not being supported or funded in doing so. So, yeah.
Okay. Sorry, I thought I was on mute then, but I wasn't. So I think we've just got time to just maybe Gillian, just coming a little bit on the importance of providers and citizens working as equal partners and communities leading this. I know we've just come away from the big knotty issue actually, and thanks Chad for saying that so eloquently, that this, we are an exclusive club here. How could we, the Health Creation Alliance has been doing this for over 5 years, and we've been trying to mainstream this. We've got this, we do this on a regular basis, but actually getting it the flooding out into the system and getting that culture change. You were battling all the way, and of course all of you are part of this. So it's a combined effort, and we need to keep that combined effort going. I loved, Gillian, your point about in every ICS area there are GPs like you, and I think that one of the things that NHS England could say is for ICSs to find GPs who are doing health creation and get behind them and help them to develop it further and help them to spread it. And I think that's one thing that could be done. I'm going to ask you right at the end, I'm going to ask you each a question, and the question is at the end is what one thing would you like your ICS to do or stop doing that would help you to develop or spread this further? So have a quick think about that. But is there anything you want to say about that point, Gillian, about the equal partners and the importance of the power shifting basically and power sharing?
Yeah, I'd love to. Before I go on to that, Marin, very quickly, I'd like to just come back to Chad's point. I guess the way I sort of expressed how we've got this seamless model where this is just working from the top to the community. It wasn't easy to get to that stage at all, as Marin knows from conversations that we've had. And it was just very fortunate for me that Lord Nigel Crisp wrote this book around the time I was trying to get going what I've described. And through contacts of him, I was connected with the lead of our ICS, Claire Fuller, who enabled everything. But it was very fortuitous that happened. And had that not happened, I wouldn't be here today. So it doesn't really answer the problem there, but that explains how I got to where I was. In terms of meeting as equals, so important. And the way that you physically meet is so important to that. Do you have your own meetings online, which many people would find awkward even if they had access to the internet and a laptop to join it? Or do you meet people where they're at, in their own spaces, on their own terms? Do you send all of your information out via email? Or do you actually use ways that people are already using, as Tal mentioned earlier, like social media, like community platforms, like real places that people are meeting and calling them, sending text messages, etc. Over time, I've learned to kind of try and deinstitutionalize myself and work in real ways according to the feedback that I get. And when should I stop there, Marin?
No, I loved it.
Okay, fantastic. And then another thought about trying to really enable communities to lead things. We've just done a piece of work mapping all of the physical activity opportunities that exist in Hawley. There are about 500. I've worked in the area as a GP for 6 years, and I think I probably only knew about 4 of them before we did this piece of work. So the next question from Active Surrey, who have supported us in doing this work, is, okay, do we have a website? Do we have a website for GPs where we list all of these things? But actually, of course, now in my health creating mindset, I'm thinking, why would we want to do that when we've got a fantastic community-led website, Hawley Online, whose editor I'm very good friends with now, and he has been enabling and promoting all of the activities we've been doing. Why would we want to host it when he can host it and we can actually give him some funding to enable him to have the time to do this? And he has, I don't know, 15,000 hits a week or something like that, or maybe more. I have no idea, but a lot of hits anyway. So it's sort of changing and trying to decondition ourselves into institutional mindsets towards more community-led facilitative approaches.
Lovely. Okay, so we're going to be finishing for a break in a moment, but just very quickly, and Ella, if you've got any more points to say, just say them quickly now, but then we'll just go around and just say what one thing very quickly in one sentence you would like your ICS to do.
Yeah, you go ahead and do that, and if I've got anything at the end, I shall.
Okay, Tal, any thoughts?
Just to have a really clear vision of what they are, what they stand for, and what they don't. stand for, because sometimes you can't be everything for everyone. So yeah, just to be able to articulate who they are and what their particular sets of priorities are. But that shouldn't be a shopping list.
Okay. Andy?
Yeah, I would say, and I'm really looking forward to hearing what Donna Hall has to say from a leadership perspective, but I think mine would be for core leadership teams to do their work. I think we keep on perpetuating loads of the kind of injustices we see because people just don't do their work. They keep on with their same fixed beliefs or ways they've always been brought up in the world. And one of the things we try and insist on, or I certainly do with my team, is please get out and sit with recovering heroin addicts, sit with people who are street homeless, sit with people who are women from the Gypsy Roma traveller community. Don't you dare make assumptions on judgment or judgments on how we should be spending money or what these communities need when you've never even heard them. You don't get to dress up in your nice posh suits and sit around a board table feeling important when you never interact with our population. That's easy for a clinical person to say because I sit with those people every day in my clinical room, but I also take time out to go meet with and sit with people living with the most staggering social injustice in our communities. So do your work would be the first thing. And the second thing I'd say is, can we please slow down? Everything is done with these 4 words behind it: at pace and scale, at pace and scale. It's killing everyone. Everyone's absolutely burnt out and overexhausted and overwhelmed. We can't do everything at pace and scale, and it's killing us all. So could we just slow down, learn to take a rest, actually build quality relationships, and then do things with wisdom and relationships that actually make a difference long term, rather than feeling we've got to change the world by next week?
Thank you, Andy. Thanks. Chad, 1 sentence, and then Jill.
Yeah, I think for me, it's probably about people-powered health. The thing that I've learned from the Deep End scheme is that absolutely everybody wants to do something. They want to be involved. They want to feel like they're connecting and doing something that's useful and making a difference. And it almost, at some point, when we were doing the face-to-face Deep End sessions, we'd get commissioners that would come on their day off to the sessions because they couldn't do what they wanted to do in their job. And so I think if systems committed to developing people, then it doesn't matter where you sit, whether you're a service user or a commissioner or what have you, you can make a contribution to improving wellbeing. I think that would make a massive start.
Okay, so commit to developing people. Thank you. Jill.
Thanks, Marin. I think I would just reiterate what I said earlier, which was to keep listening and enabling not only members of the practitioners in the ICSs, but also listening to the communities and connecting with them, as Andy said. And I loved what you said, Andy, about patience and taking a slower approach. It's so important. I like to think of us trying to grow a new ecosystem or an old growth forest. It's not a rapid plantation that we need to slice down next year. We need this to be embedded with the mycorrhizal roots and everything, This is slow work, but it's really meaningful and it's transformative.
Thank you. Ella, final word, and then when we're done.
Yeah, final word. I think it's simple, but it's true. This face-to-face and listening on every level seems to be an essential ingredient in all of this. Andy, you're talking about talking to people on street level, people you wouldn't want to talk to. That's my world. That's what I do, and I've seen how much you can do by just being one person. But to take that further can be just be so overwhelmingly powerful. So I look forward to seeing what we can do. Thank you, everybody.
Thank you. I'm going to hand back to Brian for the last word before we break for 15 minutes.
Thank you very much. Let's just have a break for less than 15 minutes, please, because I'd like us to come back, say in 10 minutes, otherwise we will run too late at the end. So 10 minutes, please. Thank you very much for a fantastic session, Marin and Ellen. It was really exciting and insightful. Cup of tea, toilet break, and back in 10 minutes, please. Okay, everybody. Welcome back. Well, that was just a most amazing set of sessions. Thank you so much, everybody, for your insights and your challenge. Start the video. Is that better?
That's better. Thank you, Brian.
Sorry, didn't realize I was off. So thank you very much, everybody. It was really, really good. Some fantastic insights and challenge there. Some fabulous examples of inspiring practice, as Jill said. It's wonderful to be with people who prioritize social justice in this way. And of course, what we need to do is to systematize this across the system. The Health Creation Alliance wants health creation and these kind of approaches that you've all been talking to be business as usual across the NHS and local authorities and housing. And systematizing it is not at all easy. So I agree with Chad that we need culture change and system change, but I'm slightly more optimistic than Chad about it, in the sense that it looks as though the system is beginning to recognize the sorts of things that we are talking about in a way that it has not before. Just to respond a bit to Andy in terms of the slow pace of things that we need to slow down. You know, I and others have been working at this for about 20 years, if not longer. So I'm quite keen that the change happens before I'm on my Zimmer frame. So let's press on in a gentle but persistent way. So I'm optimistic, slightly optimistic, because I think the 10 principles that the NHSE and I have produced are actually quite helpful, and they give the leverage, they might offer the leverage to make change. And there are lots of other organizations that are around to help, the Health Creation Alliance being one of them, that we can support many systems in moving in this health gain direction. So just to talk very briefly about these 10 principles, and I put a link to them in the chat there. What it's requiring ICSs to do is a few more detail. Agreeing a system approach to engagement, shared methods and principles, such as a system-wide citizens panel, local health champions, working with people with lived experience, health and care experience profiles and co-production, making full use of existing insights from national data sources and from place and neighbourhood level engagement, agreeing how the board will demonstrate that it's meeting legal duties relating to public involvement in health, and quite importantly, creating the right conditions for social action that supports health and well-being, for instance, including community development support. So these are actual requirements on ICSs. It gives examples of what good practice should be like. So I don't know what you think, working in an ICS now as it begins to evolve, but it seems to me that those are useful tools that we can use to highlight the things that we've been talking about today. So the Health Creation Alliance can help you create the right conditions in a range of ways to make sure that you can identify good practice, for instance, and help to spread that within your areas. And we also offer training and support in applying health creation. And one example are features of practice that makes a difference. And maybe Jim was looking for these. We include listening and responding, truth-telling, strengths focus, self-organizing, and power shifting. And we've generated these from work with communities over time. And we think these are the kind of key issues that make a huge difference in shifting in a health creation way. And perhaps another, I hope you think that it's a piece of optimism, that Jonathan Ashworth, who is the Labour Shadow Secretary of State for Health, has said we need a big push on overall wellness. It's about health creation. It's not just about what the NHS does, but how we care for people from the moment they're born to their last breath. And as Jill mentioned, he cites the book by Nigel Crisp, and we and Jill and others are in close touch with him. So Labour seems to be shifting in this direction, and the government also appears to be cognizant of all of this. So I remain optimistic. Finally, we've mentioned a number of times community development, and there are obviously lots of people on this call with huge experience, deep experience of community development. So just to say that we think a trained community development worker whose job it is to listen to local communities' issues and support them in getting them responded to is absolutely essential. We'd like to see community development presence in every PCN. And community development can be provided by the NHS or the local authority or BCSE and linked. They can support social prescribing, but they're not the same thing. And community development has been shown to improve the responsiveness of NHS organisations, support health gain, improve individual health behaviours, assist in tackling health inequalities, and be a pretty good investment with a social return on investment of about 1 in 4. So I think we look forward to, and we want to encourage and cajole ICSs to take this forward. I think we can now move into the breakouts where we can discuss these elements, both the principles and the practice, in more detail, and we'll be focusing on key health inequality priorities and also the 3 elements of the vision that Bola outlined right at the beginning. So Neil, can you split us up into the breakout rooms, please? And we'll take them forward. Thank you.
Yep, I certainly can, just to let everyone know. So you'll automatically be assigned to the breakout rooms, and there'll be one facilitator in each of those breakout rooms to help guide the discussion. And there will be 2 breakout sessions. There'll be the first one of 20 minutes, and then what will happen, that will close, but you'll stay in your breakout room, and then the facilitators will move around to another room. There'll then be the second breakout session. So I will warn everyone as well that when it's coming to the end, the 2 breakout sessions, and then there will be a 20-minute roundup session at the end. Okay, so I'm just going to randomly assign everyone. And then Ella, I will come and join you in your room. Okay, everyone should be
also something that needs to be thought about. There was also a point about the data sets, which is the point that you mentioned, and you do need to look at all the different data sets. The point taken that Andy mentioned about bin collection, really important, free school meals, single parent households, etc. However, someone did say that we focus a lot on population health, but we should really be focusing on health inequalities, because when you take the whole population, you're at risk of missing out again the people who aren't, the sort of the hardest problems. So we have to start looking at the way we do data differently to make sure that the people at the sharp end of health inequalities are picked up, are sort of, that we focus on there. I think that's it from that group. I had, do you want me to go on to the next group?
No, let's move on to accelerate preventative programs that proactively engage those at greatest risk of poor health outcomes. Did anyone focus on that?
We did, Brian.
Okay, go ahead.
So we looked at how to do that, and we thought a lot of it came down to trust and commitment, but that was shown by giving things time, and in particular thinking across the 5-year period, thinking about feedback, those kind of issues, being clear about dedicated action which understands the detail and the nature of inequality. For example, the role of women and getting the right representation into those kind of inequalities. And we also had a very innovative idea for putting money in the hands of people who co-produce by using social enterprises, and more on that from John, which we've got in the chat.
Great, thank you very much. And our group looked at militating against digital exclusion. And we did, essentially what we did was to think about ways or where other people have already tried to massage, support, encourage people who are not online to go online, which is not quite the same as supporting existing structures to enable people who are not digitally literate to keep using the services. It was explained that there are various aspects of access to the infrastructure. So if you don't have access to the internet, if you don't have hardware and you're not literate, it takes about 5 months to learn to get up to speed. Volunteers are really helpful to do that. So there's been a project in UCL where volunteers have helped people get online by doing it face to face. And the final point was made that it is really important to get people online because it makes life a great deal easier for people who haven't got much money and who are under the cost of social injustice. It saves time and it makes life a lot easier for a whole range of groups. So that was our insight into that. And if I can move on to the second breakout, who focused on equitable access?
Yeah, we just did that actually. I think what came out was we talked about language, health literacy, and there not being enough of that available, and re-establishing some of that. GPs not being given enough kudos or resources to be able to deal with, patients sort of opening up. We had a comment about trust. Yeah, there is a lot of talk about trust and re-establishing that, and mistakes that have been made, but needing to move forward from that now and finding ways to change the momentum and make it more positive and sort of move forward, acknowledging mistakes in the past. Peter mentioned about community paramedics and the amount of insight they get out and about in the community, and how data can be rather out of date and useful by the time it's received. So data can be a bit of a weapon as opposed to something that can be beneficial. So stop compartmentalizing problems into budgets is another one that came out of that. Proactive care needs. Yep, so I think that's what we got from that so far.
Thank you so much, that's great.
And we also started there, Brian.
Okay.
And we picked out, firstly, that it was kind of moving on from, if you like, tick box approaches to engagement to another level, which would be about prioritized action plans and feedback, together with accountability for doing something that's about what has been heard. And then on that theme of doing something, we felt that the kind of connection part of health creation really needed the NHS to show that it is heard. And that was going to take into controversial territories, issues about housing or the removal of the £20 universal benefit. And there's something about how the NHS behaves differently in relation to lobbying and having shown that it's heard some of the things that are impacting on health that are outside the NHS.
Mm. Yeah.
Excellent. I'm very pleased you mentioned those things. That's really helpful. Excellent experience. Did anyone tackle that?
We did that, and I think actually from the previous session as well, we looked at it a little bit. Something about unpicking a mess. There is a real sense of people are on the journey at the moment who are in both of the sessions actually, and that journey is, can be messy at times because there's a dynamic already with the community, and there needs to be a different approach. So it's good that people, that's happening in terms of the experience. Someone talked about the challenge of listening to people who aren't there very much, who don't use the services very much, and how they've used a set of what they call cards for humanity. So it's about helping people to, the professionals, I guess, to put a different hat on and think what might this be like for this person? How might it be perceived by people in different circumstances? Very interesting point. Some research has been done about people's experience of the system, and there are some touch points that are sort of common. They come up over and over again that you can focus on. So, and those 4 touch points are when you're making an appointment, when you're waiting in the waiting room, interpersonal experience with the clinician, and then also leaving hospital is another touch point. So those 4 touch points are, if you can think about how to make the experience better through all of those, then that's great. We did also talk about delivering in community settings rather than in within clinical spaces, and the importance of spaces that communities are comfortable in and that people want to be in. So are there ways of combining clinical services, if you like, with other things within the same buildings? There's a lot going on that with NHS property services at the moment, and I think I'll finish there. There were some other things, but I think that's probably enough points from my session.
Thank you so much. And finally, the optimal outcomes. We looked at the two main questions really. Optimal for whom? So should the person decide those optimal outcomes? Should the community decide? The consensus certainly wasn't that it should be the NHS to decide. What kind of outcomes are we talking about? Again, there was a huge discussion about the current outcomes that GPs are paid for are about transactional services, numbers, and saving money. There's nothing, for instance, about health creation and how might we incentivize that? How can we support practices, local authorities, and other places in actually doing that? So Heather was mentioning that when you look at different communities and the different outcomes, one community that she was working with, the priority for that community was to make sure that they weren't sleeping on the floor. So it's about trying to think on how inequalities and social injustice can be included in the concept of optimal outcomes. So thank you very much, everybody, for all of that. We will collate and put all of that together in the report that comes out of this conference. Thanks very much for all your input and your thoughts. And don't forget that we will have more of this in the 5th of October. And we will make sure that people are aware of that, of the details of that meeting where we will explore this further. So I'd now like to move on to introduce Donna Hall, well, at least we say she needs no introduction as usual, but Donna, if you could briefly say what you're doing now, and then please take it away. Thank you very much.
That's great. Thanks very much, Brian. And what a great session this afternoon with some brilliant people leading in their field. And so I'm chair of an organisation called New Local, and we passionately believe in community power as the way to kind of remodel public services around communities, and to give communities more of a say and more of a role in shaping public services in their local area. And we're just about to publish a report called A Community Powered NHS. And we've been working with NHS England on ICSs and with the Leadership Academy as well, around the different skill set that we need as leaders to work with communities in a more effective and joined up way. I also chair Bolton NHS Foundation Trust, and I am under social enterprise that delivers social care for people with learning disabilities. And I was the chief exec at Wigan Council for 8 years, where we did something with the community called the Wigan Deal, which if people are interested, there is a write-up of it by the King's Fund, which is probably the best place to start if you're interested in finding out more about it. So I've been asked to speak about leadership, and one of the strands in the document is around a different type of leadership that's required. And again, I'm an ICS advisor to NHS England, so I work with them on the guidance. So hopefully you can see it's got some of the kind of Wigan influences and some of the New Local influences and some of the great work that people like Andy, Knox and others have mentioned already today, their work. We've tried to listen in a way that I've never seen NHS guidance that's like this, really. It's quite, you know, it's quite bottom up for guidance. I know guidance is tends to be a set of rules that we have to follow, but we've really strongly encouraged NHSEI to make it much more tight on outcomes, but loose on how it's delivered, because every place is different. Every locality has different relationships with local communities. Communities are different. There's different levels of deprivation or social injustice, depending on where you're working and which ICS you're in. But what I think is really important is that the starting point for leaders is that the current system is broken. We can't continue, as Andy said in his speech, we can't continue to just prop up status quo, and we can't expect ICSs on their own without the input of communities to transform population health and to transform inequalities in a locality. It's got to come from communities and from people working right on the very coalface with those communities. So we've heard some brilliant examples today. Samira, great work going on in London, and many others as well. Fantastic work going on in West Yorkshire and Harrogate that we just heard about in the breakout rooms. Brilliant work, but it's not like that everywhere. You know, I sit around some tables at an ICS and sometimes at an ICP level, and I hear very much a top-down command and control, KPI focused discussion where leaders are not exposed to real people, and they have an assumption about how people live their lives which is not based on reality, and they don't listen and they don't get out there, and they're quite hermetically sealed. So I think it's really important that the more leaders can get out there and listen to communities, the better. I've always tried to build that into the way I work with in any system or any organisation I've been part of. I think the second thing is that good organisational leaders are not necessarily good system leaders. Very often, particularly in the world of acute hospital trusts, you get quite heroic, very kind of command and control type leadership, which is kind of, we look upwards for a set of rules from NHS England and then we implement it at pace and scale. You know, we take no prisoners and we just do it. And that's great, it gets things done, but it doesn't change the culture. And as Chad said, the real deep difference that will come from ICSs is a deep-rooted culture shift. Within the way that we work with local communities, how we listen to them, how we learn from them, and how we don't just assume that access to our services is what they want. Sometimes our services are completely the wrong thing, and all we do is we restrict access to our services when we get a budget cut, and we think that's a good thing to do. But actually the services themselves are not shaped around the reality of people's lives and the families that support them. So I always use this personal example of my mum. She sadly passed away 5 years ago, but when she was discharged from the hospital that I now chair, 22 different bits of health and social care came up her drive on one day, all of them in the wrong order, none of them asking about the family support network she had in place. And none of them relating to her as a person, very much around a medicalised assessment of what was wrong with her, rather than thinking about what she wanted, how she wanted to spend her last days on this planet, and how they could make that happen for her. So, you know, a huge shift in the way we work with people, integrating care and wrapping it around them and thinking about them as people, as human beings, in the way that we would all want to be treated. And leaders who get that, you know, everyone I think on this call has kind of exemplified that type of leadership, asset-based, human to human, you know, based on compassion and kindness, rather than a kind of very medicalised, process-based silo model. We did some work. What led to the creation of the Wigan deal was some work we did with a woman called Hilary Cossum about 10, 11 years ago. You'll have read Radical Help. It's a great read. What's more difficult is to put the lessons from Radical Help into practice in a local area, and that was the Wigan deal. That's what we tried to do. And we tried to do it at scale and pace, but it took 10 years and it's still going on, because this is not an easy thing to do. Deep cultural shift takes time. To even start to see a difference takes 3 to 5 years, in my experience. But it starts with local communities. It starts with frontline teams, working in integrated place-based teams around primary care networks, integrating with schools, integrating with drug and alcohol services, mental health services, housing, and having a plan and a support network in place for risk stratified families that you've identified are at risk of having a child not ready for school. We heard earlier on, you know, Marmot's work around the impact of not being ready for school and the first 1,000 days of life. We know those babies before they're born, but we don't do anything in advance. We sit and wait for them to arrive at school not ready for school. We don't work as a system to prevent that from happening by proactively reaching out and providing parenting support, speech and language development, attachment support. We don't do it. We have a very reactive approach to public services in this country, and that's not the case in other countries. We had more visitors from Denmark come to see us in Wigan than we did from, for example, the rest of Greater Manchester, because they have a completely different approach to public service delivery. Leaders are not the only leaders in the system. I think I pinched this from Rob Webster from West Yorkshire and Harrogate, but leadership is a distributed model. It should be leadership leading from every single seat in the room is how we lead, and really working hard on that. It's not the way the NHS works traditionally. And we need to challenge those, you know, those big beasts, those big silverbacks in the NHS trust world who want to battle each other to be the best and to be at the top of the tree. That's not the way we will be successful if we're going to deeply transform our integrated care systems and our organisations. We need to lead with boldness, but we also need to lead with humility. And it's that combination of bold humility that will get us to where we need to be, in my view. I think in terms of NHS England's leadership as well, I think there are some really kind of deep lessons that we need to learn. I really love the ICS guidance. I think it's definitely a step in the right direction, but it's got to be backed up by behaviours. So, for example, in terms of funding allocation, we saw earlier this week the King's Fund did a fantastic report around elective recovery and around waiting lists. And basically, if you live in a poor area, you're going to be waiting longer to get treatment and to get support. So funding allocations need to be based on poverty and deprivation and social injustice, rather than just treating everyone with the same, thinking that they're all on the same level playing field and beating people up when they don't achieve what they're meant to achieve within the timescales. It's not fair. It's not going to work either, because poverty is a real driver of health and health inequalities. So, for example, in Greater Manchester at the moment, we have a full hospital full of people who are medically optimised waiting for social care. And yet social care has been cut for the last 11 years. So it's pointless funding the NHS unless we address the deep-seated issues in social care. And we know that when Beveridge created the welfare state, he forgot about social care. He remembered a few years later that basically it wasn't women's work just to look after people, that he needed to fund social care properly, but by then it was too late. So we need to fundamentally address the issues of social care if we are going to address health inequalities and create a health creating society. So I'll leave it there if that's okay. Brian, hope that's given you a bit of a flavour around the type of leadership that we need for the future.
That is fantastic, Donna, and very, very much appreciated. I think we have spent an appropriate and important part of our afternoon together talking about social injustice, talking about poverty, talking about the social determinants of health. And what we're all saying here, I think, is that health creation has a part to play, but it only has a part to play. The rest of the government and the system have to think about how, as a whole, the economy deals with injustice and poverty, and we have a very long way to go before that happens, I'm afraid. But within that, I think the ICSs offer us an opportunity to work together to systematize the kind of insights that we've seen today. So the insights about working with community, the insights about cross-sector working, the insights about community development. So all of those contribute together to hopefully make ICSs a different set of organizations. And I think what Donna has done, maybe with the guidance, maybe that's why I thought it was such good stuff, because Donna has been behind it. I think that helps a great deal, but we still have an enormously long way to go. And we all on this call who are doing our work in our various places have a huge part to play. And just to finally leave you with the message that the Health Creation Alliance can really support ICSs and PCNs in a range of ways. So for instance, we can help identify good practice in your area. We can offer discovery learning programs which help the whole of your system move in a health creating direction. And all of that can be tailored to your requirements, to your patch and your needs and your the different people in your areas. So we will be sending around information for the next meeting, which will be on the 5th of October, where a lot of the learning and so on can be consolidated from what we've learned here. And we look forward to seeing you all at that meeting again. And I think Neil will be sending details around. Thank you so much, everybody, for your insights, your contributions, the chat, which will be bursting when we save it all with so many insights. Thank you very much and keep up the good work. And we hope to see you again soon. Thank you very much, everybody. All the very best. And claps to everybody. Well done. Thank you so much.
Well done. Thank you, everybody.
Goodbye. Thank you very much indeed. Take care. Safe journey home.